here, and I think it's really a nice opportunity not only for the physicians to present some of the work going on in this very complicated area, but to see some new people that I haven't met and some of my existing patients from Mayo here who've also made the trip out east for what I think is a productive meeting. And my work is really, I'm a neurologist, but I see a lot of MS, I see a lot of transverse myelitis, and I do most of my research in tissue pathology. And what that means is the study of brain and spinal cord. And that's been kind of the focus for me in part because I think of it as the lesion is ultimately our target for therapy. I mean, we're trying to prevent it or trying to treat it once it happens. So perhaps by studying these tissues closely, maybe we can get some better ideas about what's going on, causing the damage, and how we might better treat this disease. Now, I actually start first just from a slide from my colleague, Dr. Weinschenker, who you'll hear from later. But basically, we all have heard that transverse myelitis comes in a lot of shapes and sizes and different varieties. And basically, it can be part of its own syndrome in some of the isolated transverse myelitis syndromes that we've heard Dr. Lin talk about. It can sometimes overlap with multiple sclerosis as being perhaps a presenting sign of it or even occurring within the context of established MS. We've heard from Dr. Irani and others that acute disseminated encephalomyelitis can sometimes be associated with transverse myelitis. And even Dr. Katz has talked about this progressive necrotic myelopathy. And then recently from Dr. Mandler and Dr. Wingerchuk and others, we've heard about this Devic syndrome. So there's a lot of places where transverse myelitis seems to kind of fit in here. And the question here is, are these all different causes, different etiologies, different treatments? And if so, perhaps by studying some of the more well-defined forms such as Devic's, which I'll be talking about, maybe that can give us some better clues on how we can understand transverse myelitis in general and how we might better design treatments which can help patients. So with that in mind, my study is really a pathological study, as I said, and it's really titled A Role for Humoral Factors or Mechanisms in the Pathogenesis of Devic's Disease. And we heard a little bit earlier that there's two major arms of the immune system, the cellular arm and the humoral arm. And the cellular arm deals with mainly T cells, which mediate damage to tissue, whereas the humoral arm, in very simple terms, reflects more with respect to B cells, antibodies, and complement. And basically, it's important to perhaps distinguish these because there's drugs that seem to do a better job of targeting cellular versus humoral and vice versa. So with that in mind, we've heard nicely from Dr. Wingerchuk that neuromyelitis optica is one of these families of inflammatory demyelinating disorders, or part of the family, with these conditions or attacks confined to the optic nerves and the spinal cord. And as we heard from Dr. Pardo, and I know it's a bit hard to see this purple color, but some of the established pathological features were actually very nicely described by Dr. Mandler, and these included the presence of this necrosis, which we've heard about, is basically dead tissue. Cystic lesions, which basically mean holes within both the gray and the white matter. This whole issue of inflammation and specifically T cells has been quite variable. And Dr. Mandler and now Dr. Pardo has also talked about the presence of funny-looking thickened vessels. Perhaps there's an apparent increase. But basically, the pathology does seem distinct from MS and might provide some clues about what's going on. We heard also that the disease tends to have a severe course, and it tends to have a normal brain MRI, so the actions going on in the spinal cord predominantly and the optic nerves. These lesions are aggressive, they're large, they extend many levels. We heard about the fact that the spinal fluid tells us there's a lot of activity going on with respect to the presence of cells, and sometimes even the presence of neutrophils, which like to come into tissue that's been necrotic or dying tissue. And we've also heard that there's, similar to transverse myelitis, no effective long-term treatment. The other couple interesting things is yesterday people were talking about this association of transverse myelitis and connective tissue diseases like lupus and Sjogren's. Well, what's interesting about Devic's is that about 45% of patients, when we do some of those blood tests to kind of screen what's going on, have a high prevalence of autoantibodies within their blood. And if you start to look at the literature, even the old literature about, let's say, lupus or Sjogren's, often we see that when they present with neurologic findings, it tends to involve the eyes, the optic nerves, and the spinal cord. So is there any clue here that something about the autoimmune and the humoral side of the immune system could be specifically targeting the eyes and the spinal cord in particular? As we'll hear from Dr. Weinschenker and alluded to by Dr. Wingerchuk, plasma exchange seems to help many of these patients in the setting of their acute, often devastating attack that failed steroids. And that's interesting because plasma exchange theoretically could do a better job of removing antibodies that could be in part responsible for the tissue damage. And then I'll talk about a nice animal model of Devic's disease in particular, and one in which we might be able to better understand what's going on when the spinal cord has been damaged immunologically. And that's a variant of the EAE model called MOG-induced EAE, and we'll get into that just a little bit later. So as a pathological study, what were the aims of me and my colleagues and myself? And that was, number one, to determine really the pattern of inflammation, to look at the blood vessels, to look at the cells that make myelin, called the oligodendrocytes, to look at the extent of white matter damage or demyelination, and to look at those nerve cables called the axons and see to what extent they are damaged in this condition. And then finally, to better understand the importance of humoral mechanisms such as complements, antibody, and B cells in causing this condition. And what this was based on was on 9 cases which were collected both at the Mayo Clinic and kindly from my colleague Raul Mandler in New Mexico, which consisted of very well clinically defined cases. They were all autopsy cases who unfortunately died in the majority of the situation from respiratory compromise, as we heard can be a complication, as noted by Dr. Wingerchuk. And many of these cases were in fact actually from the 60s, the 70s, and a few more recent. We also were interested to look at Devic's with respect to MS, so we had a series of 73 active MS cases, acute disseminated encephalomyelitis in 5 cases, and also some spinal cord infarctions caused by either AVMs or postoperatively in certain aneurysmal surgeries, which were both either new or chronic infarcts. Now our patients, again, mainly fit the relapsing bill you heard Dr. Wingerchuk talk about, with 8-to-1 female-to-male ratio, average age about 50, but a big range, 16 to 80. 8 were relapsing and 1 was monophasic, with the average disease duration, unfortunately, just 2.5 years. A half-and-half split, who presented with eye findings versus who presented with spinal cord findings. And then the cause of death, as I noted, was unfortunately respiratory compromise. Interestingly, there were 3 patients with a total of 4 associated autoimmune diseases, which is kind of interesting because we often don't see that association with MS. And we had 2 with associated hypothyroidism, 1 with pernicious anemia, and 1 with thrombocytopenic purpura. We did a lot of stains, and I won't belabor this, but it's basically a number of different stains you can apply to tissue to look for specific things. We also looked at a number of techniques called immunocytochemistry, in situ hybridization, and all this has really been an advent in the last decade or so, the fact that we can get these stains working in this kind of a tissue, and it's kind of giving us a bit of a new look at the pathology and causes of these conditions. And as a first step, whenever you look at a lesion, you need to kind of determine how long it's been there. In other words, is there signs that the myelin is actually being destroyed, or has it been there quite a while and most of the activity is all gone? And that's important so we can try to ask what's going on as early as possible. So we want to be looking at that earliest stage where myelin is actively being destroyed or gobbled up by the macrophages. So this is just an edge of a lesion from a Devic's patient. We heard about that myelin stain from Dr. Pardo, with blue being myelin, and here where you don't see the blue, it's been a wipeout of the myelin. And if you look closely at these cells, see these kind of cells, clear-looking cells, these are called macrophages, and they come into the tissue, and they're full of these little brown dots, and that's actually a marker for myelin called MOG. And these little brown dots tell me that this lesion is new. It's actively chewing up the myelin at that time. So maybe I have a chance to sort out what might be going on at that early stage. We staged all our lesions with about 36 active lesions, 35 inactive, meaning no myelin was being broken down, and 8 remyelinating lesions, which, yes, in the nervous system does have some capacity to repair and put myelin to some degree back onto the axons. So 79 lesions were looked at. And then we wanted to look at not only myelin components, those cells that make myelin called the oligodendrocyte, all different kind of inflammatory cells, immunoglobulin, which again we're trying to get at this idea of humoral mechanisms, complement components, and the vasculature in particular. And among the complement components, we look in particular at one that's called C9neo. And complement is a cascade of proteins that, when activated, can directly damage tissue, can basically put holes into cells and tissue. And C9neo is a marker that that has occurred. So it's a very sensitive way to tell us that complement appears to have been activated in the tissue. So let's just start on the kind of long picture show here to go through what this looks like. And this is a representative case of Devic's disease. Here's your spinal cord. Here's the gray matter in this pinker area, and the blue area is the white matter. And what you can appreciate is this enormous lesion, which seems to basically have completely involved both gray and white matter. It basically looks like a bomb has gone off in the tissue. It's very aggressive, very destructive. And when we look at this same area, this is highlighting macrophages. It's a stain for those cells that can gobble up debris and also cause damage. And what you can see, that whole area is chock full of these macrophages. So although it's not so inflammatory in the T cell side, there's plenty of macrophages which are part of the inflammatory cascade. Now in terms of the axon, that's that nerve cable that the myelin is covering. And when you look at axonal damage in neuromyelitis optica, it's significant, which means if you look here at the stain that marks these axons, there's a marked decrease in axons. At times there's big holes in the tissue. If you look closely, the axons can be often swollen or have these areas where they're kind of called spheroids, where there's transections. And this seems to be more dramatic and more significant than what we see in most cases of MS. This doesn't project so well, but PLP messenger RNA is a way to look at those myelin-producing cells called oligodendrocytes. And in addition to the loss of axons, those myelin-producing cells are also essentially wiped out, which if you look at this lesion edge, here's where the black little cells, or those oligodendrocytes, are still present. But if you look into the lesion in here, they're basically gone. Again, just a testament to how aggressive and destructive this process can be. The issue of T cells, while I would agree that it's variable, it is definitely present to an extent. And the question is whether or not there's so much necrosis we're not seeing as many T cells. But in any event, this is a stain for CD3 and CD8. And you can see actually here plenty of T cells in this area, CD3 and CD8 labeled cells. But I agree that it tends to be less overall than typically seen in MS or ADM. And we talked about those macrophages. Again, this just highlights this intense sea of macrophages flooding the lesions, as you can appreciate here on higher power. These are all those little macrophages. Now, when we look a little closer at the inflammation, there's kind of something unique that became apparent when we looked. And that was, although there weren't so many T cells perhaps, there was a striking infiltration of two kinds of cells called granulocytes or neutrophils and eosinophils. And that might sound, well, what's the big deal? But the fact is that eosinophils can be very dangerous cells. They're kind of sometimes referred to as the kamikaze because they can come in and destroy. They're more toxic than even the products of macrophages. And when you started looking in at the lesions, there are these redder looking cells present throughout active Devic's lesions, and this intense neutrophil infiltration also present in active areas, not just in that dead necrotic area where you might expect them, but even outside of those areas. And then to look a little closer, I use this stain for what's called eosinophil major basic protein. And what that is, it labels one of the actual toxic proteins within the eosinophil. And when you can look here, this is the H&E, the regular section. And this, all those little green cells are actually eosinophils. Plenty of them present in this active area. And this is for eosinophil major basic protein. We also found those in what are called the meninges, or the covering of the spinal cord. And not only were they present, but they were degranulated, which means they didn't just come in for kind of watching the show. They were actually participating in this destructive process by releasing these toxic granules, which you can see here outside of intact eosinophils. So they tell me that they were functionally active, and they could even prove to ultimately be a target for therapy, since they previously weren't really recognized in Devics. And together with my colleague in Cleveland Clinic, Dr. Ransohoff, who you'll hear from later, interestingly, we saw the expression of something called CCR3, and that's a receptor for a very potent chemokine, eotaxin, which basically is a very potent recruiter of eosinophils. So it made sense that this was around in these lesions. But similar to MS, we saw CXCR3 and CCR5 in the lesions, really not in a pattern too different from MS. It was this CCR3 kind of going along with the eosinophil story here. Now, I've kind of set the backdrop for the inflammation, but so in the end the question is, well, what's the clues that there's anything going on humorally in this lesion? And that's really by a series of stains in which first we looked at immunoglobulin deposition. And what we saw was a very striking two patterns of deposition in these lesions, the active lesions. One was a deposition of immunoglobulin around the vessels in these thick rimmed areas. And the other was this interesting rosette pattern, which seemed to spill out outside of the vessel, and you had this intense deposition as well. Interestingly, it was more prominent for IgM versus IgG, which is relevant to us who are in the field in that that's a better fixer of complement, that protein I told you that can be pretty destructive in the lesions. Now, this pattern was interestingly reproduced by that C9neo staining. That's that staining that there's now been activated complement in the tissue, and it looks like it's causing some destruction. So again, you see this interesting pattern in red around these thickened vessels, similar to the immunoglobulin staining, and in this intense rosette pattern, very similar to the IgM staining I showed you. In fact, co-localizing. This is just a higher power to highlight that again, this rosette pattern and this rim pattern. And note this thickened vessel in this very early active lesion. So it's not just a question it's been around for a long time. This was a young patient. This was occurring early in the disease process. And then finally, not just the immunoglobulin with the complement, but the macrophages, when you look closely in these areas, follow this similar rosette and rim pattern. And again, at higher power, you can appreciate that as well with the rimmed pattern and rosette, apart from the sea of macrophages we showed earlier. Then the question came up, well, what about those vessels that we all seem to think, those who look a lot at Devics, something's not quite right there. Well, this stain actually allows us to look at some of the thickening of the vessels. It's a Movat stain. And here the green is where there's increased collagen deposition. The vessels are thick, markedly thick, and numerous. It doesn't project the greatest here. But the question is now, is this a response to the injury, or is this reflecting a target of injury in these areas? So in trying to kind of put it together and comparing it to MS and our control samples, T cells and macrophages are present in Devics disease, they're present in MS, they're present in ADM, and they're even present in spinal cord infarctions. But this unique pattern of perivascular rosette and rim staining for immunoglobulin and C9neo is actually restricted in this pattern to Devics. Although we can see a deposition within MS, it is in a very different pattern, which tends to be along the myelin edge rather than around the vessels. And eosinophils are actually markedly present within these Devics lesions. We have one very fulminant case of MS where we saw some eosinophils. But if we look at even just the active lesion, every active lesion had eosinophils and neutrophils. Here this is also consisting of, however, some chronic lesions, which is why our numbers come to 56%. And then these thickened vessels are present in these Devic cases. So what does that all tell us? Well, a few summary things until we get into this discussion. These are destructive lesions. They have prominent blood vessel changes. You see this evidence for eosinophil and neutrophil infiltration. We find this vessel or perivascular reactivity for immunoglobulins, more so for IgM. And we see this pronounced complement activation in these sites. So really this is speculative, but what could be going on? I mean, what's causing this co-localization? Well, if you think in your circulation, you've got these T cells and B cells, and in some people what are called circulating immune complexes. The possibility is that maybe you're having a reaction to an antigen sitting in that vessel or perivessel space with a specific antibody that causes a specific reaction, or maybe you get the deposition of immune complexes that are out in the circulation. They come in and they can trigger an inflammation, which in either situation can trigger the activation of complement. And that's the bad guy in this situation because it's coming in and causing some of this damage. So the complement can bind here to the antibody, and then this actually causes macrophages, those cells that kind of gobble up the debris, but it causes them to swim on in and get activated. And then they can either bind via complement receptors or FC receptors on the macrophage and immunoglobulin to now cause this next wave of destruction. Basically what happens is all kinds of cells can be pulled in, such as eosinophils, granulocytes, and they release a number of toxic chemicals that can damage that tissue. And interestingly, as you get a lot of swelling with these lesions, I'm certain that there's a component of ischemia. And that's probably because you have to remember the spinal cord's in a fixed space. So as it's kind of expanding, it's starting to compress, often into the central portions. And that's probably also why some of the active EAE lesions, they're often in the central portion of the cord. In any event, it's a combination of this type of damage, which you might release some new antigens when you break down the myelin. But in any event, it's kind of propagated here, and it could be that all this started out here around these vessels. Now, some can say, well, complement activation. Those of us who are in neuropathology or immunology will say, well, if you take dead tissue, sure, you're going to see complement. But in fact, we did not identify it in acute spinal cord infarcts, where you can also see necrosis. We did not see it in white matter infarcts of the brain, and it was not restricted to those necrotic areas. It was often seen outside in those areas where the activity was just coming in. And then those eosinophils, well, this got me a little excited because this really wasn't really recognized and hasn't really been a target of therapy, although it's a big area of therapy in diseases like asthma with new drugs coming along. But here we saw the numbers were elevated in Devic lesions. We saw that they were functionally degraded, functionally active, and they were degranulating within the tissue. And as I mentioned, this CCR3 expression is a principal receptor for eotaxin, so it's probably contributing to eosinophils coming in. The question is whether the eosinophils are primary or secondary, because actually, once you've activated complement, one of the components, called C5a, is very potent at bringing eosinophils in. But it's also good at activating them. So they're probably working in tandem here and contributing to the tissue damage and may provide avenues for therapy. I mentioned these eosinophils being pretty bad guys in this situation. We usually think of them in the setting of parasites or allergies, but the reality is they contain a number of these toxic proteins, what are called reactive oxygen intermediates. They can also release what's called platelet activating factor, which can make those blood vessels more permeable, causing more swelling, and a number of cytokines, including IL-4, what we have traditionally thought of as the so-called anti-inflammatory cytokine. In this case, it may be very different. This may be mediating damage in a very pro-inflammatory kind of a way. Interestingly, if you start looking back at the literature, there was a report in 1976 of a child who had eosinophilia in the spinal fluid, and they called it a case resembling childhood MS. Yet, in fact, this patient had recurrent episodes of transverse myelitis. There was a case in 1980 where a patient had eosinophils around the eosinophilic vasculitis, inflammation around the heart called pericarditis, and low complement levels. And when you looked at the case and read the history, this patient had recurrent episodes of optic neuritis and paralysis, perhaps an unrecognized case of Devic's. And just this past year, they were describing an autopsy case of Devic's in an Aboriginal population, where they noted, boy, there were lots of eosinophils. But they attributed this to the fact the patient was getting beta interferon, which can at times cause eosinophilia. However, none of our patients received beta interferon, and I suspect they were seeing what we were seeing and likely unrelated to beta interferon. Now, why target the spinal cord and the eyes, and what's unique about these areas, and does this give us any clue about transverse myelitis in general? It's possible that there's a restricted antigen there, which means it's just expressed in those sites. I think that's unlikely. More likely is these areas are particularly vulnerable when that barrier that tries to kind of keep the, it's called the blood-brain barrier between the peripheral and central nervous system, peripheral systemic circulation and the nervous system separate, that there's certain places that's inherently weak. In fact, your spinal nerve roots, as they come out from your spinal cord, lack a blood-brain barrier. So it's conceivable if out in the circulation you've got these bad antibodies, it wouldn't take much necessarily to get them into the spinal cord and start the cascade. Interestingly, if you look at some of the trauma literature, we can also know that the spinal cord responds a little more aggressively from an inflammatory standpoint than it does to the brain. In fact, you can take a cut within a spinal cord and see that neutrophils will come in caudal and distal to that injury to a much greater extent than if you did the same cut in the brain. So this might account for why these lesions tend to be longer, more aggressive, and more necrotic than what we see in the brain. And finally, just to close on this relationship to a model, because ultimately models are where we need to kind of put certain hypotheses to test and test certain drugs and things like that. And there's a model of EAE where you can give T cells an antibody to something called MOG, a myelin protein that is expressed on the surface of myelin and oligodendrocytes. And what's interesting is you can take a rat, but you can change its background such that on the one hand it could be a DA genetic rat versus a BN rat. And depending on its genetic background, you can drive either this cell-mediated process, which I mentioned earlier, or this humoral process with the B cells, complement, and antibody. You can also use the same antigen and under certain conditions drive more of the humoral response. Now what's interesting is when you drive this humoral response, you tend to get the same topography, lesions in the optic nerve and lesions in the spinal cord. Not only that, you tend to see eosinophils. So something about the immune response or someone who might be predisposed to a humoral response may conceivably target these areas preferentially. And this just highlights that in those cases in which spinal cord and optic nerve were involved in the rat, 17 out of 19, or almost 90%, had eosinophils within their lesions, compared to those with about a third spinal cord-dominated pathology having eosinophils, and only one where the lesions were up in the brain where we saw eosinophils. So, in conclusion, humoral immunity could be important in the pathogenesis of Devic's. The perivascular space could represent the primary site of target. CNS eosinophils could contribute to pathology, and perhaps ways to suppress either the antibody, the complement, or the Th2 response could help. Something that is actually kind of contrary to what we think in MS, because usually we're trying to increase the Th2 response because we think that's anti-inflammatory or shift to that response. So in light of that, what are some of the strategies that have been used? Well, currently we've heard of plasma exchange, and perhaps there's a role for IVIG or more specific B-cell immunosuppression. Experimentally, why not try to go after that complement cascade and try to block that? Perhaps blocking C5a or the formation of the attack complex that mediates some of the damage. Perhaps certain strategies that are anti-Th2 cytokine or chemokine strategies, or ways to block leukocyte migration. So with that, I'd like to acknowledge my collaborators. Apart from those at the Mayo Clinic, Brian Weinchecker in Rochester, Joe Prees, our pathologist, and my technician, Patricia. Of course, Raul Mandler, who's been instrumental in the intellectual and sharing of material as well, aspects of this study. Richard Ranzahoff and Corinna Treps at the Cleveland Clinic, who've been instrumental in the chemokine studies. Dean Wingerchuk, you've heard speak from Scottsdale, Arizona Mayo Clinic. and one of my key collaborators in University of Vienna, Hans Lossmann. Thank you very much. Well, I was interested when I saw your optic nerve because it looked active. All the optic nerve lesions that I have are actually remyelinating or inactive. So I can't address that because they need to be early actively demyelinating lesions. But your chiasm there looked like it could be. It was pretty hypercellular, and I didn't see that close up. But it would be interesting to see. So we can't for certain answer that. We can say that, interestingly, remyelination, at least oligodendrocyte kind of remyelination, was within optic nerve, and very minimal Schwann cell remyelination in the periphery of the cord, but otherwise I can't say. Okay, thanks.
Okay.